Hey, good evening, everyone, and welcome to your favorite show, Ask Dr. Saw. I cannot say how pleased myself and Dr. Saw are by the response that we've been getting from everyone, and it's so wonderful to have so many people coming on board with the show and sending in the questions and engaging, especially. I love the engagement, and I know we have some really good fans who have been following us on the show, and they're really being part of this unique presentation of information from a medical perspective by none other than Dr. Saw himself. Dr. Saw, how are you doing?
I'm fine, thank you. And you?
Very well, thanks. Still a little bit of the cough, but yeah, it's going away. It's going away. Yeah, it's a little nagging at times, but I think I haven't done my part also to make ensure I keep drinking a lot of cold things and so on too. So that doesn't help the situation. But is that a myth? Or, before we start the show tonight, is that a myth or is it really? You got a cold, you got a flu. Does drinking cold things make it worse? Could it prolong it?
Sure. No, that is true to an extent. And the reason is there are some microorganisms in your body that they strive or they multiply in that type of environment. In moist, humid environment, you can have a multiplication of microorganisms. So when the place is cold, when your body temperature is cold, when you're in that state, possibly, you can have multiplication of the germ and it can prolong it. So there's some theoretical science in that.
Wonderful. Dr. Sutton, tonight we're talking about a very important topic, urinary tract infection, UTIs. And, it's a lot of, from last week, many of the questions were coming in last week because of what we were dealing with were to do with UTIs also. So I'm happy that we're having this conversation tonight. I'm happy that we are going to bring this to the fore. And Dr. Saw, I would start off by asking you, first and foremost, what is a UTI? And as a follow-up, why is it that it seems that more women are susceptible to this to UTIs and not so much men?
Yeah, that's a good question, and I'll get to that. I thought that today's topic would be a follow-through from last week's topic, and it will allow us that smooth flow, because we didn't get to cover lots of things. Half an hour sometimes is a little bit too short, because we can end up talking for hours.
Yeah. Time goes by.
But yes, coming back to UTI. So UTI is, by definition, urinary tract infection. And what it is, it's an infection of the urinary tract. And as I explained in the past, the urinary tract comprises of the kidney, and so you have two kidneys at the top by your back that goes down into your abdomen, the tubes, and then it leads to the bladder. So the kidney, those two kidneys, blood flows into the kidney, then it leads down into two tracts they call ureter, and that connected to the bladder, which is like a reservoir, and it leads out to the urethra.
Urethra, yes.
And that's what you pee or you pass urine through. Now, anyway along that route, if you have infection, an infection is microorganisms. So these are bugs, right? And you can have bugs. Bugs are divided into different types. You have bacteria, you have viruses, you have parasites, you have fungus, how there are different types of microorganisms, and they all can cause infection. Now, it is also extended in men. Urinary tract infection, we can also categorize something called prostatitis. So the prostate, which is the outlet of the bladder, you have a walnut-shaped organ, which is called the prostate, and it can get infected, and that can comprise part of UTI. And as you go down to the testicle, epididymis, which is the tubes that store the sperm, you can have infection there that are linked to urinary tract infection in men. So men can have a little extension of urinary tract infection that can involve the prostate and the epididymis. That's the testicle. Good. So we've got the definition as to where the urinary infection is and what causes it is growth of microorganism. And they're common microorganisms. So the second part of your question, you asked, why is it more common in women? Now, if we look at the way urinary tract infection is caused, or the majority of causes, is due to what we call ascending infection. So infection moves from the perineum area. So the perineum area is the area around the anus and the vagina.
Right. That's space. Yeah.
Yeah, that little part there. So there are bacteria around there. So there, as you know, there are lots of bacteria in our skin and generally in our body. And the bacteria there, it ascends, as in it moves up the urinary tract. Now, why women get it? Men urinary tract leads into the penis and it's a long tube.
Right.
Whereas women, it's a short tube from where their outlet is, where they pass the urine, to the bladder is a very short tube. And because it is easier for you to have ascending infection, that's why it's more common in women. And secondly, you have the perineum, the opening opens in the vagina, and that area which is more exposed in many ways to the rest of the body. So you have a likelihood of anal and perianal and perineal infection ascending upward. So that's a common cause, and I suppose there are probably other genetic predisposition, the anatomy of the body. Women also tend to, and one of the risk factors, I'll talk about that, stagnation of urine. Women, we can go and pass urine anywhere.
Right.
Stop out of the street and you can do that.
I don't recommend it. I don't recommend it. It's a very it's not a pleasant sight to see, man. But you know what? Sometimes we just can't make it. We just can't make it anymore. I understand.
Women generally they hold the urine more.
Yeah.
For bladder bursting to go, and they have to wait until they get home or
they can't go being a lantern post.
And that is a predisposition because when you have urinary stasis, so you have urine build up in the bladder, the bulk stays for longer and they multiply more, and you can have more risk of urinary tract infection. There are other risk factors. Generally, pregnancy is a risk factor. So, woman gets pregnant, so generally diabetes as a risk factor, and certain immune suppressed condition. If you're, weaker, your body system is weaker, you get that. And patients who are born, there's some people who are born with malformation of the urinary tract. So you have a double opening of the, where you pass urine, or you have duplication of the urethra.
Right,
there are some malformation generally predispose you to it.
Yeah.
And patients with kidney stones, that's another risk factor.
Yes.
So these are called risk factors of urinary tract infection.
Yeah. But Doc, I know somebody who had a woman, of course, who had a UTI, and I can tell you that it was very, it was very painful for her. What are some of the symptoms that accompanies a UTI?
Right, fine. So we talk about symptoms.
And what are some of the flagship, the red flags that we need to, as soon as you see those things, you need to get on the ball.
Fine. So generally, it has to do with how bad the urinary tract infection is, right? So I have seen patients with mild symptoms. They just say, Doc, I feel a discomfort down below, or discomfort in the abdomen. And when you test them, that's a urinary tract infection. Now, if the infection stays and it gets more progressive, then of course you have other symptoms. But let's start with the basics. The basic, you would have symptoms of what we call dysuria. So dysuria means painful or discomfort in passing urine. So when you go to pass urine, you feel a stinging sensation, a burning sensation, or some form of discomfort, and that is called dysuria. Now, you can also have incontinence. So normally, yes, when you want to pass urine, you can make it in the toilet. Some patients, they just get incontinent. They can't pass urine. Or Also, sorry, not they pass too much urine. You can also have retention where you can't pass urine.
Right.
So you have retention, you have incontinence, then you have frequency. So let's say you're going once a day or twice, well, not more than that you generally go, but let's say you're going 4 times a day, you may end up going 4 times an hour. So that's called frequency. So you have increased frequency, you can have plus or minus incontinence, you have dysuria, that is discomfort. Then you may have abdominal pain, so lower tummy pain in your where your bladder region is, the pubic area. You have pains there, and that can give rise to it. You may see blood in the urine. Hematuria, we talked about blood last week, which can be a sign of urinary tract infection. Patients and children especially, they can have, and elderly patients, they can have bedwetting. So suddenly they wet their bed, and that may be a sign of urinary tract infection. Your urine may be smelly, and that is a giveaway as well, a sign of urinary tract infection. Now, as the infection progresses and it go higher, it can get into the kidneys. You have back pain. So instead of tummy, you have back pain. And if the infection progresses so badly that it gets into the blood system and you become septic, it can give rise to serious illness where you're hospitalized. You're actually generally weak. You have high temperature. You shiver, so rigors, fever, temperature, and it drops your blood pressure. So urinary tract infection can lead to sepsis, which can be fatal if it's not treated in time. You heard of sepsis when
yes,
there
of
is
course, yeah,
in the blood.
Exactly. In the blood, yeah.
Now, it is not a trivial condition. As a matter of fact, they said the second most common cause for antibiotic request in a doctor's surgery is for urinary tract infection. The first cause is upper respiratory tract infection. That's your sore throat and your cough and cold and chest infection. And the second most common cause for antibiotic request is urinary tract infection.
Wow.
So it's a very common condition that we see, and most women would have urinary tract infection at some point. And then there are other types of urinary tract infection. So you have what we call a recurrent urinary tract infection. I'll come to that in a minute. But that's your sign and symptom.
Right. So, if a patient, if somebody is suspects that they have this and they're at home, they're not close to a doctor at that point in time, are there any further investigations or any method that they can use at home to determine whether this is or not?
Yes, indeed. So we have specific tests that you can do to establish objectively that you have a urinary tract infection. They have just published some new guidelines on urinary tract infection, however, and the guidelines stated that if patients are symptomatic, that is about enough evidence to say they have UTI. Right. Because I will go through the different tests, and some of the tests are not very they are not sensitive enough to tell you 100% that you have urinary tract infection. So a giveaway would be morning sensation or discomfort, urinary frequency, and smelly urine. You can say, fine, he's got all the classical signs and symptoms, abdominal pain. I would treat blindly without testing. Because if I were to test and that test is negative, it can still be a urinary tract infection.
Okay.
So no test is 100%. Put it that way. So we better to treat than not to treat. But I will tell you some of the tests that we do. So you see the doctor can take a sample of urine and they dip it into they tell you, give you a bottle, pass some urine in it, and they have a strip where they dip the urine into the strip and they have a look at it. So what we are looking for white blood cell. So on the strip, it's got different colors.
Right.
And when you look at the color changes. Let's say from red to green or red, blue, green, whatever. So the color change will tell you if it is positive or negative to what you're looking for. So in UTI, we look for we look for white blood cell in the urine. So leukocytes, you will see it says positive or negative or plus, plus, plus. That's a sign, that's a giveaway. And the sensitivity of leukocytes is about 80%. So 80%, if you dip that, you could say fine. Of all the positive people, 80% would show up. You can miss 20%. So that is called a sensitivity of a test.
Right.
So
right.
not because if that is negative, it means you don't have it. Remember, it picks up 80% of the positive people. So we would say, fine, that's a clear-cut urinary tract infection. Nitrites, you have something called nitrites, also on the strip that you look at, and the nitrites has got a sensitivity about 50%. So you can miss 50% of people. So half the people, and that is why I said there is a limitation to the dipstick test. So
Right.
not because you go to the doctor and the doctor dip the test next to you and say, fine, this thing is positive or it's negative. You have to know the different parameters and how sensitive they are to pick up 100. So that's not 100%. So what we will do, and then you look for blood, you look for protein. You know, they're different.
Relying on chemical reactions to show the different readings. How does a strip really work? I've always wanted to know this.
Yeah, well, the strip is a reagent strip, and it's got some. So it depends on what. When you're looking at, it has a yes, it causes a chemical reaction onto the strip.
Mm-hmm.
So whatever the reaction is, so if you have blood, it creates a reaction onto the reagent that you use, and it changes the color. So you're looking for those chemical reaction that changes the color on the strip.
Right. Thanks. I just wanted to know that. Yeah.
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 So
yeah. Go ahead.
So these are strips that anybody can use. It's John Public can use that. You don't need to be trained into it because it's guided by a color code.
Right.
So you look at it. The bottle will have a different color when it's negative, positive, and then you use the color code to tell you that this is positive and you've got it. Then, of course, a blood test can show you that you have infection. If there is also, you can have blood from a urinary infection. It can move, the infection can get into the blood. So when you get sepsis, we can also test the blood to see if there's bacteria in the blood. But that's when you have overwhelming infection. But we look at a basic infection. So that's your classic urinary tract infection. Diagnosis, very simple. You either do a dipstick or you send the urine off to the lab and then you test it. But when you're looking for like a recurrent infection and trying to find out why this patient is having so many infections, then we can go and look in for the urinary tract and see if there's any abnormality, if there's any retention, if there is an obstruction. So if your prostate is big and you can't pee all the urine out, you may have retention of urine. If there's any blockage anyway, you can have a retention. It increases your risk of urinary tract infection.
Doc, can a STI present itself like that of a UTI, and then you have an STI and you're thinking that it's just a urinary tract? Is that possible?
Correct. An STI, as you know, you said, well, just for the viewers, sexually transmitted infection. So you can call it STI or STD.
Right.
So sexually transmitted disease or sexually transmitted infection.
Yeah.
And 100%, STI can present like a urinary tract infection. 100%. STI can present like a urinary tract infection. 100%. STI can present like a urinary tract infection. 100%. STI can present like a urinary tract infection. 100%. And the thing is, the giveaway, however, I'll tell you. So the common STI that you can have, chlamydia, gonorrhea.
Mm-hmm.
So the STI that attacks the urinary tract, the urethra, it's just called urethritis. That's your passage where the urine comes through. The bacteria gets into there and it causes infection. But the giveaway, generally, sometimes you get discharge. So if they are pussy discharge, normally urinary tract infection would not give you pus coming out of the penis.
Okay.
Or the urethra or the vagina that you've got pus coming out. Whereas an STI you may have. But I'm saying not everyone will get pus. But usually if you have pus coming out of your urethra, I would say fine, this is probably an STI rather than a urinary tract infection. Yes. So gonorrhea, you'll get pus coming out. Chlamydia, it's not an infection. And these infections also, chlamydia more so, can be asymptomatic. Women can get chlamydia and men, and they don't even know.
And chlamydia can affect you long term?
Long term, of course, it can get into women. It can affect pregnancy, like getting pregnant, because it can cause infection in the tubes. It can cause blockage of the tubes in women, so they don't ovulate, or they get blockage. They ovulate, but the flow is not smooth. And it causes something called pelvic inflammatory disease, PID.
Wow.
And that can prevent pregnancy and cause problems. So it is not a trivial condition that we take lightly. You need to ensure you take a history, and when you test, you can know that. And we tend to do urine tests, also can test for chlamydia and gonorrhea. The other type of STIs, I mean, you have other STI. I'll do a topic on STI separately because besides chlamydia, gonorrhea, you have some viruses like herpes virus, cold sore in the animal, is type 1, genital herpes type 2. But herpes shows a wound. You'd have ulcers. So those are giveaway. But you can have ulcers that you get burning. So you can get ulcers by the vagina area or the penis area, and patients sometimes don't pay attention. And it burns when they pass urine, and that when you examine them, you find ulcers, and you say, fine, this is herpes, causing the burning sensation rather than the urinary tract infection. So yes, the answer to that, STI, correct.
Let's talk about a little bit of prevention before we go to treatment, because I remember one of the questions that from last week when we were talking, somebody mentioned that using public washroom facilities, toilet you're at risk of having a UTI. What are some of the prevention methods, and is that true?
In my opinion, that is not true. For the majority of cases, it's an extreme. Theoretically, it's possible, but that's the extreme. The probability of that is very, very low, and I'll tell you why. So people say that, and I
hear that often,
Yeah, but we have a tendency to find a cause always and attribute things to, right, this is the cause, and we know this is the cause. Half of the time, we don't even know the cause. But it is very unlikely that you use public toilet and you have a urinary tract infection. Maybe you can have other types of infection. You can have a fungal infection. You can have a skin infection because you sit on the toilet seat and you pick up a fungal infection from the toilet seat onto your skin. Now, for you to get a urinary infection, you have to sit in such a way that the bacteria gets onto your private parts.
Yeah, not just by
not just touching your buttocks. You sit on the toilet seat of a woman I'm looking at.
Yeah.
They sit on the toilet seat, the buttocks touch your toilet seat. How on earth can that buttocks bacteria now get into the vagina?
Right.
So it is not a likely cause. As a matter of fact, that has been published. And people say that all the time, and the evidence tells us it is a very, very low probability of contaminated toilet causing urinary tract infection. And people, they've got a tendency not to use public toilet. And as a matter of fact, by not using the public toilet, they are increasing their risk of having UTI because they're causing stasis or backup of urine into their system. So the evidence tells us that no, public toilet doesn't cause UTI. Theoretically, if there is a probability that is so low, it's really not the case, because majority of cases come from perineal infection. E. coli, there's some special germs, E. coli,
right.
Coccus. And yeah, so it's really a bit.
In my research for this topic tonight, I saw that E. coli is one of those bacteria that is most common in UTIs. Is that so?
That is correct. E. coli accounts for more than half of half to three-quarter of urinary tract infection. So yeah, it's the most common bacteria.
Right. One more thing before we move on to treatment. Okay, so I was married for 19 years, so I've had some experiences where, and I'm one of those guys who would go in the supermarket and call my wife and ask her if she needs sanitary napkins, or what we usually call pads, or liners, or whatever the case may be. She always tells me, do not buy the scented one, because that will give her an infection. Is that a myth also?
Not necessarily. It is possible, and it depends on the individual.
Right.
So you can have scented, or you can have any form of fragrance that your body tolerates, and you're not sensitive to it, and you don't have a reaction. But anything that causes sensitivity can cause irritation, and irritation can increase your risk of UTI. So it is the sensitivity of that person to the fragrance that is more important than the actual product. If the product was known to cause UTI, the company wouldn't make it.
Yes.
Obviously, they would say fine. But most people, they're not sensitive to those fragrances. But if you find that you're sensitive to fragrances, then I would advise you not to. There are some risk factors that predispose you to infection. Anything that causes irritation of your bladder. So there are patients who use things like tea, coffee can cause irritation of the bladder, alcohol, smoking, spicy food, they cause irritation of your bladder. And of course, they can also predispose you in some way or the other. When we come, you asked me a question about prevention, and we didn't get to talk about that, and I'm conscious that the time is probably coming to an end.
So we're gonna close off. And in the next half an hour, let's because we are almost at 30 minutes here, and I don't want to get cut off in that. So in the next segment, we're gonna do let's do prevention and treatment, please.
Okay, fine. Okay, yeah, we're happy with that. So at least we have touched on what is UTI. We talk about some of the signs and symptoms of UTI. We talk about how do you get it. We talk about the risk factors that predispose you to it. We talk about the investigations of UTI. So I think we've covered a good chunk of that. And in the next segment, I suppose we can take a break. And then we come back to the next segment, but there are lots of other questions from last week.
We're going to cover them. Yeah.
So hopefully, unless you want us to spend 3 minutes and talk to that, so we complete UTI.
Yes, of course. Of course, we're going to complete UTI. Yes.
No. Do you think we have 4 minutes? We can.
No. We have time, Doc. We have 9 minutes remaining. Just show up. So we have enough time to cover it.
Okay. Well, let us cover UTI so that at least this become a separate.
Exactly.
If you want to spend half an hour looking at this alone, they can do, and then we cover the questions in the next one.
We have enough time.
But we can take UTI questions in the second half.
Yes.
But okay, let me talk prevention quickly.
Indeed.
And spend another couple of minutes on this. So, prevention we talk about, you should void when you want to. That is, void past urine when you want to. So you don't keep your bladder full and cause stasis of urine. So frequent voiding. You should drink adequate water. So water, important. It flushes the urinary system. And if the urine is concentrated, of course, it gets irritation and it causes more. So you want to drink adequate water, adequate voiding. Now, we are talking non-pharmacologic means. That, you get it there. That's why I have mine as well.
Indeed.
That's a vodka in it.
All right, Doc. I hope you stay on topic tonight then.
I'm joking. Right, okay. So back to my
prevention.
Prevention. Cranberry juice and cranberry products are known to prevent urinary infection. It prevents the bacteria from growing and multiplying in the bladder. So cranberry product, be it cranberry juice.
Yes, I've heard about that.
Sauce or cranberry, whatever you want to use. Some patients use that. And then you have what we call pharmacologic ways of preventing UTI. And so pharmacologic would be in medication now. We can start with women. They can use estrogen. So in elderly women, postmenopausal, they have low estrogen. Low estrogen cause skin to get a bit, lose its, its composition in some ways. So you probably have more dry skin and more dryness of the vagina and mucous membrane, and more irritation. So you're prone to more irritation. And so you can have injury easily. You have bruising, especially after sexual intercourse. You can have more bruises. And ascending infection bacteria just multiply and grow when the environment is right. How do we prevent that? You can do that by taking FORCE, natural lubricant, so KY jellies and those whenever you have an intercourse. But there is a special estrogen gel that we use in the vagina. We prescribe that. And I would say to women, do not use this if you have symptoms. It is very minimal side effects. And lots of people are worried that I'm taking hormonal treatment, but no. The hormone is so minimal that it doesn't, the amount that is in the body is insignificant because it works more locally. So if you take, let's say, HRT, you're taking hormone by mouth, it gets into the blood system and you have a higher concentration of the hormone. Whereas when you use that topical hormone, it works in the vagina and it lubricates it better, it improves the health, and it improves the bacteria, the type of bacteria that lives in the vagina. So estrogen, topical estrogen is important. There is a tablet called metamine hypourate. Metamine hypourate. That's another tablet that you can use as a prevention. Again, it prevents the growth of bacteria in the bladder. So these are things we use to prevent urinary tract infection. And patients who get recurrent infection also, we give them antibiotics. Antibiotics on a low dose every night. So every day, daily dose, I would give them a low dose of the antibiotic, like the same antibiotic we use a treatment, but at a higher dose. And in these patients, we give them once a day a low dose of antibiotics. And these are patients who have got recurrent infection. So if you have the definition of recurrent infection is having 2 or more urinary infection in 6 months, or 3 or more in a year. Then we consider you as a recurrent UTI, and we would want to find the cause and treat it. So estrogen can be one of the things we use. Also, we can give prophylactic antibiotic. You take a low dose every night. What I tend to do and what is recommended is that every 3 to 6 months, you switch the type of antibiotics. So I can give you one for 3 months, then another 3 months, another type, because I don't want you to have resistance.
Right.
And in the management of UTI, very simple. If you get all the classic signs and symptoms, antibiotics is a management. Lots of people go over the counter and they can use the cranberry products and all these over the counter sachet and stuff. That's all okay if you use that and your body has got ability and you have simple UTI, you probably can fight it on yourself with those products and it goes away. However, if it gets more and more symptomatic, you'll come for antibiotics. Antibiotics can be used at different types depending on the local setting. Common ones are nitrofurantoin, trimethoprim, cefalexin. We use, there are some newer ones now, phosphomycin. So antibiotic can be used from a week, you can use it for 5 days, you can use it for 3 days, or you can use it for 1 day. Phosphomycin is used 1 day. If you get simple UTI, so these are all simple UTI. If you have simple UTI, you can use antibiotic phosphomycin, 1 dose, 1 day, that's it. You can use other types for 3 days, for 5 days. In complicated UTI, however, where you have other conditions going or it's going to the kidney, I would want to treat the patient for 1 week. So it's important. Signs of UTI, once it's classical, you get some antibiotics from your doctor ASAP.
Right. Doc, I read also that it is recommended, especially for women with UTIs, to wear loose on the clothes and not too tight, and to wear a different, probably cotton instead of sort of latex and so on.
Absolutely. So we talk about that,
Spandex,
and we say the humidity is very important. And if you have aerated clothing where air passes through and it's not tight and the clothing is such that you have, you change the environment of the vaginal area, you can change the bacteria and how the bacteria grow and multiply in that area. So those are all important factors. And also for thrush, like vaginal infection, it also changes the local bacteria that lives in the body. Mm-hmm. So I think our time is up now for the fourth segment.
Right. So
we'll close here, and then if you are happy with that.
Yes, of course I'm happy with that. We have some questions to look at from last week, and we'll continue on that after the segment.
And we'll ask patients, viewers, if they send questions on UTI, and of course we pick them up next week. So if there was something we didn't touch on, we can touch on it the following week.
Viewers, just a reminder, we are doing the first half an hour of the show. This is our new format. We do the first half an hour where we do the education program, where we talk about the topics that we're going to be discussing for the evening, which is tonight's topic is UTI, urinary tract infection. And we are going to then, on the next half an hour, we are going to be taking your questions from last week. And I know there were a number of questions that came in last week, so we are going to be, myself and Dr. SAWH are going to be looking at those questions in our next segment. Stay tuned. Hi viewers, welcome back to our next segment where we are going to be dealing with your questions from last week. As I said, you don't have to stick to the topic. You can ask any question and we will deal with it. But if you have questions about UTI and you're sending in those questions as you are right now, we are on our next program on next Tuesday. We are going to be answering those questions. So we have a few questions from last week, which I'm going to be presenting to Dr. SAWH now, so that we can get these covered. Doc, welcome back. Oh, he hearing me?
Yeah, sorry. Can you hear me?
Yes.
I did not get that.
Okay, so I'm saying, right, we're going to start with the questions from last week.
Sure,
Yeah. So the first question we have here is, somebody says, medication damage your kidney over time?
Not necessarily true, but some medication can do. So let us look at the story. So lots of people tell me this. I have patients come in all the time and they say, Doc, like if they have diabetes and high blood pressure and whatever condition they've got, and we tell them they have to use medication for life, they say to me, well, medication will damage my kidney. Well, the drugs generally, you take it into the body, the liver metabolize it, and then it gets excreted by the kidney, or it can get excreted in the bowel. So you can excrete it, either way. Now, indeed, there are some direct drugs that can be toxic to the kidney, where they damage parts of the kidney, the tubes. So the kidney gets, we call it, where the blood flows, it gets some tubules, and there are drugs that can do direct damage to that. However, by and large, most of the drugs that we use for chronic conditions, they are safe to use in the kidney. And for instance, because this is something I really want to touch on clearly for patients to understand this. When patients have diabetes and high blood pressure, actually, if they're mild, yes, lifestyle is very good and that can control you. But really and truly, as your condition and the natural history of these conditions, they get worse with time. So you may start with mild diabetes, but as time progresses, it becomes very severe and it damages your organ. Now, if you don't take medication, if you're worried that, okay, this medication is going to damage my kidney, it is of no consequence versus if you don't take medication. Because if you don't take medication, the condition itself is damaging to the kidney and the heart and the eyes. So you know diabetes damage your eyes. People in the old days, people used to lose their leg. You know how many people lose their leg because of diabetes. High blood pressure damage your kidney, damage your eyes. And I would say to everyone, no, not all medicine damage your kidney. There are some toxic ones. I'll tell you some of the toxic ones. So painkillers generally can be bad for the kidney. especially NSAIDs, we call them. So things like ibuprofen, naproxen, diclofenac. Have you heard of those drugs?
Of course.
Ibuprofen, we know them. Advil.
Yeah, I've been using them.
So, correct. They can damage your kidney, so we don't want to use that. There are some antibiotics. We call them aminoglycosides, vancomycin, not the common ones, not your standard amoxicillin and tetracycline and stuff. They are strong antibiotics can damage your kidney, but these are patients who already have kidney disease. By large, the majority of antibiotics don't touch the kidney or do any damage to the kidney. If the kidneys that are already have damage, then it can be where you have to reduce the dose or you have to make some adjustment. So there are drugs like metformin. If your kidney is already damaged, it doesn't damage your kidney, but if your kidney is already damaged, we want to reduce the dose of it. Even a blood pressure tablet, like ACE inhibitors, a drug called ramipril, or the other sets that call ARB, like losartan, valsartan. Whenever you have kidney damage, or if you have a kidney, let's say when you're very, very ill, or you're dehydrated, we would reduce those dosages of those tablets for just a period of time, for a short period of time, until your kidney recover. So here it is. There is a condition called acute kidney injury. Mm-hmm. So when you are dehydrated, when you have some toxins in your body, so even if you have, let's say you have sepsis, you have an infection, even pneumonia or whatever infection, you're vomiting, you're dehydrated, so there's less blood flowing into the kidney to wash the kidney and everything out. Certain medication can cause more injury to the kidney. So we tend to restrict or reduce the dose or stop it for a few days. And these are the drugs. We call it SADMAN. So SADMAN would be, S is sulfonylurea, is a diabetic tablet called sulfonylurea. A is ACE inhibitor, is a blood pressure tablet called ramipril, lisinopril, captopril. D is diuretic, so water tablet.
Right.
You're already dehydrated, I don't want to give you more water tablet. Mm-hmm, mm-hmm. MAN, SADMAN. M is metformin. Metformin, we will reduce it because it will damage the kidney if you're dehydrated or if your kidney is already damaged. MAN. A is ARB, which is family of ACE inhibitor like lisinopril, but they're called candesartan, losartan, irbesartan. So we'll reduce the dose or stop it for a few days. And where's the other one? N is NSAIDs, ibuprofen, and that family.
Oh, wow.
So by and large, you don't take the position that all drugs are going to damage your kidney. You got to discuss with your doctor, okay, I'm on this drug, my kidney is a little bit dodgy, then they will make adjustment to the dosage. But I would always say to patient, take your medication unless you're told otherwise. Okay,
excellent, Doc. Thanks for that. Next question is, what causes swelling in the feet in a diabetic patient?
Right. That's a very, very loaded question. I can spend the next 2 hours talking about swelling of the feet because it is so common and there are multiple causes. But let us zoom in a little. I think that's another, put that as a point to note that we will do a topic on swelling of the feet.
Okay,
because this is really a big topic. So let us go through swelling of the feet. In a diabetic patient, why I would zoom it into a diabetic patient, because the diabetes affect the heart and the blood vessel generally, right? So we have cardiovascular effects. So we're assuming in a diabetic patient, swelling in the feet can be caused by a heart and blood vessel damage. So the common cause would be, first thing, what you have to establish, is it swelling of both legs or feet, or is one side? Just your foot on one side. If it is one-sided swelling, we would look at something that is localized. That is, fine, there's an injury on one side, or there's a blockage like a blood clot on one side, or one of the blood vessel is damaged in some way. So that's or you got arthritis on one side. So we're not looking at that. We are assuming here is due to diabetes. So normally diabetes affects the whole body. So you wouldn't get swelling on one side, you'll get swelling on both sides.
Okay.
Now, if you have swelling on both sides, importantly, you have to establish that this is not coming from your heart. So the common cause, heart failure. So diabetic patient, they tend to get heart failure as a long-term complication. Or high blood pressure patient, they tend to have vascular problem and you get heart failure. You can get heart failure from just being hypertensive. You can get heart failure because you have angina and a heart attack and a damaged part of your muscle. So what is heart failure? Heart failure, the heart pumps, and if the pump is damaged, so the muscle is pumping, so part of the muscle is damaged, be it from high blood pressure, be it from a heart attack where the muscle didn't get enough blood supply and it's damaged, the pump gets weak. So what the heart does, it can't pump strong enough. Mm-hmm. So if it gets a pint of blood coming in, it's only squeezing out half a pint.
Wow.
Instead of squeezing out the full pint. So what happens? Naturally, there is a buildup of fluid in the heart. Mm-hmm. And that then causes pressure to build up into the veins, because the vein returns blood into the heart. So if there is extra blood pooling up into the heart, the vein can't push it up.
That's right.
So what happens? It backflow, or you get, backup of blood into the veins, and they get congested, and you get swelling of the leg. So that's a very common cause in diabetic patients where it is heart related. So everyone that comes in with swelling of the leg in a diabetic patient, I first and foremost got to ensure this is not coming from the heart and it's not heart failure. And the test to establish that, you do a test called an echocardiogram. So you do a scan of the heart, and the echo shows how strong the muscle is pumping, and we calculate something called the ejection fraction. So what percentage of blood comes in and pumps out? That is called the ejection fraction, and that tells us if there is heart failure or not. And then, of course, that can be managed accordingly. One. So heart is one. Secondly, kidney problem. Diabetic patient, they all ended up with kidney impairment. So the common cause for chronic kidney disease is diabetes. So we would always check, is your kidney damaged? You know that kidney expel fluid. All the tea and the coffee and the water we drink every day, it passes through the kidney and you pee half of it out.
Right.
That's the water. If that mechanism is failing, you'll have a buildup of fluid. Where it goes into the leg. Because the leg, gravity pulls everything down. So the blood vessel get congested, and the fluid from the blood seeps out from the blood vessel into the tissue. So you get what we call tissue fluid. So if you take your finger and you press the legs on patients, it gets sunken.
Right. There's an indentation after you would move your finger.
Exactly. So that is fluid in the tissue. Tissue fluid do that. And that is because the fluid comes from the blood, seeps out into the tissue. Now, so kidney failure would do that. So, of course, diabetics, you got to look out for kidney failure. And another cause, which is not so common in diabetics, liver failure. So the three organs that we look for somebody coming with kidney with swelling of the leg, we look for heart failure, kidney failure, liver failure.
Okay.
Common one. In kidney also, sometimes you excrete a lot of protein. So the kidney is not totally failed, but it is damaged to the extent that you seeping out protein. If the protein is low in the body, protein creates something called oncotic pressure. So in school, we do something called osmosis. You used to put water on one side and salt water on the other side, and you see how the water shifts towards the salt.
Yeah.
That is because the salt attracts the water as to balance the electrolytes. And there are some protein in the blood. It creates something called an oncotic pressure. So for the blood, the liquid in the blood to stays into the vessel, you have to have some attraction to the water. Because if you have water in the vessel, in the blood system, the water can seep out into the tissue. But why it doesn't seep out? It doesn't seep out from the blood. Remember the blood vessel is porous. Mm-hmm. And the blood, if you put blood in there, it's like a strainer, it's supposed to strain out the blood.
Right.
But that doesn't happen. There's a mechanism whereby the protein in the blood keeps the water inside the blood. And that is called, it keeps the oncotic pressure of the blood. And if your protein is low, for whatever reason, so malnutrition can do that, you're going to get swelling of the leg because you're malnourished.
Right.
Or if you feed in the protein, or your liver is not producing enough protein, for whatever reason, if that oncotic pressure drops, the water seeps out and you get it into the tissue, and that could cause swelling of the leg. But by and large, the majority of patients with swelling of the leg, they get weak veins. And they jog, they stand all day, so they hang their feet down. So you sit at the desk, your vessels are all, varicose vein is probably the most common thing I see in my practice, generally, than actually a complication. But my job is not to think of the best case scenario. My job is think of the worst case scenario and then exclude that. Then I say to the patient, I'm happy, your heart is good, your kidney is good, your liver is good, your blood vessel is all right. I think this is a result of varicose vein. And another condition, and this is a tablet lots of people are on, amlodipine. Amlodipine or amlodipine, whatever you pronounce it as, is a blood pressure tablet that people use that can cause one of the side effects. So how it controls the blood pressure, it relaxes the blood vessel. So if the blood vessel relaxes, more blood gets into it, and you have more pressure that seeps out into the leg. Especially if you have varicose veins and weak veins. So one of the side effects. So I always tell patients, if the swelling is new, have you started a new drug called amlodipine, or a family of the amlodipine category? It's called calcium channel blocker. And if that's a cause, then we can say, fine, maybe this is a cause. But still, I would want to exclude other causes. But yeah, by and large, weak veins, varicose veins. So when you sit, you try to put your legs up, and you manage that by taking water tablet. Let's go.
Right. Let me diuretics though, because if somebody's having they're having issues with retention of water, so they got to take they got to take diuretics. And they already have a bad kidney. How is that going to work out? From your experience?
So we still give diuretics in bad kidney because the diuretics don't damage the kidney as such. But if you're already dehydrated and the blood flow is not enough, the diuretics even shrink the blood volume more, and it can predispose it. But if your kidney, let's say you get 20-30% kidney, it's working, you're not dehydrated, that's how the kidney is working, you could still take diuretics.
Okay.
So it is more if your blood volume is diminished that is causing hypoperfusion, that is low blood flow to the kidney. That is what we want. So you can have a kidney that is working 30% or 40% and the blood volume is good, so you have enough blood volume, and I still give you diuretic because you have taken in extra volume in your body. So we want the kidney to push that extra volume out. But the kidney is still working 30% or so. So I can still give you diuretics. So it's not a contraindication. It is all about balancing up, that I don't give you too much to then cause your blood pressure to drop, which then affects the kidney because the blood flow to the kidney gets affected. And when you have hypoperfusion, that is low blood flow, it damages the kidney more.
Okay,
so that's the concept. So the patients sometimes get worried about that. They say, fine, doctor says to them, you've got chronic disease, kidney disease, or you have kidney impairment, and they have a blanket thing, I can't take water tablet. The answer is no. As a matter of fact, more so you need water tablet, because if the kidney is not filtering properly, sometimes I need to give it a little boost.
Okay, wonderful. Next question, Doc. Can glaucoma lead to cancer in the kidneys?
On top of my head, I would say no, that there's no direct, as far as I know, there is no direct link that glaucoma leads to kidney cancer or vice versa. However, there are associations.
Okay.
And let us get this clear. So when we look at cause-effect, we're talking this thing is causing that thing. And we haven't established that. In the literature, they haven't established that there's a cause effect on glaucoma and cancer of the kidney. But they have established an association where chronic kidney disease and glaucoma are linked.
Okay.
So let me explain this. So chronic kidney disease, usually kidney impairment. Impairment is occur because of diabetes, high blood pressure, or some vascular problem, right?
Mm-hmm.
So the blood vessel issue. And the same issue can cause in glaucoma, where you're producing these fluids and cause a pressure in the eye, and you're balancing the pressure. The high blood pressure and damage to the blood vessel can cause glaucoma. So the same very risk factors for diabetes, high blood pressure, and kidney disease can also be the same risk factor for glaucoma, and they can be linked. The only other thing that come to mind, there are some genetic condition whereby there are problems with your blood vessel in the kidney, like something called tuberous sclerosis. So there are some syndromes where you're born with, and you're born with an abnormality of your genetic abnormality that gives you a condition from birth, and they damage the blood vessel in the eye, and that can cause glaucoma, and they damage the blood vessel in the kidney.
Okay.
So it can cause kidney problem, and also they can increase risk of cancer in some of these conditions. There's a condition, von Hippel-Leyden condition. There are loads of genetic, small, rare conditions that can be linked, but I don't know of direct cause and effect.
Okay, great. Next question, Doc. Good night. If you are troubling with your stomach, and when they put down the camera down, they say that they see a mass.
Right.
Can you explain that? I mean, this is a question. It seems serious.
To the viewer on that question, and usually that's a serious condition. When we put a camera in, so the intention of putting a camera, that person in the stomach, that person would have got some GI symptoms.
Right.
So either fullness of the stomach, or they're losing weight, or they're bleeding from the stomach, or they can't swallow properly, or they get bloating, or some problem. So you go in, you have a look, and you don't see anything, or you see an ulcer, where you say it's an ulcer. But when you see a mass is a growth.
Right.
And a growth generally is a tumor. So let us clarify this. A growth is a tumor, and a tumor can be cancer. So tumor just means a swelling. So you can have a tumor which is non-cancerous, like you have a fibroid.
Right.
A fibroid is a tumor, but it's benign.
Yes.
It's non-cancerous. And then you have a proper tumor, another tumor that is cancerous. So you have tumors can be divided into benign and cancerous. So when the doctor, generally, when we put a camera in and we see a mass, we start to say, fine, we can have an idea that this looks cancerous. Or it look, like if you see a polyp is like smooth and clear and fine, this thing is well defined, whereas cancer is very haphazard, it's wild. So you go and look at it and it's all over the place. Scattered, the margins are not smooth, it's all over. And generally that is cancer. So what we will do, we'll take a sample of it, and then we'll send it to the lab, get a confirmation, and then we'll say to the patient, fine, this seems like cancer. And then they have the grade, the cancer, is this aggressive, non-aggressive? And then we'll say, fine, management, we can either surgically excise it, or if it is advanced and it's spread all over the body, you may just do what called palliative care, just to prolong life and make you comfortable. So you may just put stents and things to manage, just manage the symptoms. And but that I would be a little bit more cautious, that there are a lot more. If somebody say mass, we tend to be worried, especially in the stomach. But the fact that they have put a camera and they found the mass, no one would leave it as that.
Right.
They would have taken a sample already
Okay.
They would have sent out that sample.
Or they should have.
And they should have. Yeah.
Yes.
That's a standard procedure.
Yeah.
I would think that it would be negligent for someone not to do that.
Okay, great. Doc, can chronic alcohol use cause blood in the urine?
The answer is yes, through different mechanisms. So alcohol generally can be toxic. So it depends on how much alcohol you're using. Alcohol by itself can be toxic. Alcohol can have a direct effect on your heart, on your kidney, on your liver, where it is poisonous to the body in many ways. You drink too much. It can cause something called acute tubular necrosis, where it damages the tubes in the kidney. Mm-hmm. And as a result of that direct damage, you can have blood in the urine. So the answer, yes, alcohol can do that. But so alcoholics, that would be excessive alcohol in alcoholics or so. Secondly, alcohol can cause problem in your blood system where it affects your liver, and your liver produce what we call factors in the blood to keep the blood stable. Mm-hmm. If you don't produce these clotting factors, the blood gets thin and you bleed, right? So you can't stop bleeding. So alcoholics, they can have excessive bleeding. So any slight trauma, they bleed profusely. And likewise, that can give rise to blood in the urine. So, those are the kind of things you can get from, alcohol use.
All right, this last one here, I'm very, this person that sent this question here, she's been with us from day one on this show. So here's her question. Doc, I saw crystallizations of stones in my eyes, turns hard rocks. The tears turn to hard rocks.
Well, no, that's a serious one and a hard one in terms of, I have never seen that.
Right.
In 30 years plus of practice, I've never seen that.
Yeah.
But I would say to you, that is where the tear itself gets crystal. You've seen crystal in the eye, so the cornea can have crystal. So the cornea, if you open the eye and you look at the clear bit on top of the brown bit, that's called the cornea, you can have crystallization in the cornea. And there are certain metabolic conditions in the body where you have crystal formation. So you can have the tear coming out, and if you have corneal crystallization or crystal in the conjunctiva, it can come down as a crystal.
Right.
So sometimes you can have crystallization from the tissue in the eye that manifests as if when you tear now, it brings down those crystals, right? So let's say that's one possibility. Mm-hmm. But the tear duct can produce crystal in extreme cases, and I've never seen it, but the book literature will tell us that is a possibility. There are conditions like crystals gout. You have crystal formation in gout, mm-hmm. where the crystal gets into the joint. So you can have conditions like that. If you have dry eyes where the fluid in the eye becomes dry, I suppose you can have a bit of crystallization as well, crystal formation. So some dry eye can cause crystallization in the tear. And there are some metabolic conditions which can give rise to crystallization. So those are the things that come to mind. But I'm sure an ophthalmologist would have seen, more eye conditions. Eye is probably a more defined specialty where they may have seen those crystallization. But in, general medicine, we don't see that commonly. I haven't seen that really. I've seen it in, not a tear, but I've seen it in cornea.
Okay, great. So Doc, those are our questions for tonight. Thanks so much for
pause there a little. Is it at your end?
Yeah, you hearing me?
Okay.
Yeah.
Sorry, I can hear you now. Yeah.
Right. So I was saying, Doc, thanks for all those wonderful answers to these questions that our viewers were sending in. Again, viewers, continue to send in your questions. Doc is going to take those questions, and he's going to give you the best answer possible. Today one came up where he said you've never seen that crystallization. I hope that viewer, you take the advice of Doc and
see a specialist. I would want them to
see a specialist, right? So again, viewers, thank you so much for joining us tonight. It was another great night to present this type of information to the public. Doc, anything you want to say? When are you coming back, Doc? You're still in England, are you?
I am indeed, yeah. I'm trying to sort my daughter's got exams,
Okay.
and I'm trying to support her.
She's in the medical field also, eh?
Yes, she's final year, University College London. So this is her final exams she's taking.
All right.
So, around trying to support her, and
Yeah.
yeah. That's gonna finish, by February.
Okay.
And around the end of Feb. So I think after that you'll see me.
Brilliant. And hopefully we can have her on the show sometime too.
Indeed, of course.
It will be still. It will still be Dr. Saw.
You're right.
All right, Doc. Thank you so much for joining us tonight from all the way in England. This show comes to you every Tuesday night at 8 p.m. As I said, share it with all your family and friends. Let them know about this because all of these things that we're discussing, like some of the stuff we're discussing here, it makes me feel like I want to go. Like I do this running, and I'm always on this healthy path. Now I want to even do more because now I want to put more flow into the heart, because once the heart is flowing, it seems as if that takes care of so many different things. Keep the heart flowing. So from TVN Studios, I want to say good night to everybody. And as I would always say, stay healthy. Anything from you, Doc?
No, thank you again, Akash, and your team, and thanks to the viewers for